Good morning to all. It is a great day today for its Engineers Day and an apt today to achieve a milestone for the International Institute of Information Technology, Bangalore. And the milestone is our new e-health research center. The EHRC is an outcome of the initiative of IIIT-B to do applied research in the use of ICTs to meet the healthcare needs of the underserved and marginal population groups in India and similar regions across the world. The government body of IIIT-B advised a program for this caliber, and our director, Professor Sadgopan, has initiated it with the help of the e-health committee. The goal of us being to work passionately towards enabling leveraging information and communication technology to expand the research and quality of healthcare in India. There are several players in this arena, including several of our guests today. Today we are joining you. The launch of this center is an important one, especially for all the stakeholders to know the journey we have embarked on. We would like to welcome our esteemed guests, faculty, students and staff to join us celebrate this milestone for this institute. We would begin today's event by lighting up the lamp. Lighting symbolizes knowledge. The ghee symbolizes negative tendencies and the wick is our ego. The significance of lamp lighting ceremony is that when lit by spiritual knowledge, the negative tendencies get slowly exhausted and the ego too finally perishes. We would now request our director, Professor Sadgopan, our Dean Academics, Professor Desiraju, and our guests for the morning to kindly join us and come up to the dais and light the lamp.
You should start.
Just stand around. There will be somebody else to go.
So please.
It's okay. There's so many wigs.
So very good morning everyone, and so welcome to opening of our e-health research center, that is EHRC, and my role is to talk about the IIIT-B's what are the things we are doing and what are the plan of our this particular lunch event. So we are welcoming all of you, my esteemed colleagues and guests and the students and researchers to this event. And as you know, IIIT-B is a deemed university and it is by the government of India, by UGC. IIIT was initiated by the government of Karnataka in 1998, and to our credit, by 2014, the NAC accredited us as a category, that's the highest categories of universities in this country. That is our achievement. And we have this following research areas in IIIT-B: computer science. In that area, we focus on algorithms, security, and the systems. And data science, we work on database design, search engines, analytics, and access control to electronics and health record. Some of the you will see in the green color, those are the ongoing projects going on in IIIT-B. However, other areas also we are doing research and other activities where we can take it to the medical science. So in the electronic systems, you can find electronic system design, electronic devices and sensors. And networking, communication and signals, we have been working in the areas of protocols between devices and networks. In the network, in particular, we worked on body area network, that is BAN, local area networks, LAN and MAN. And in medical image processing, so we have a group working with NIMHANS, getting the data and analyzing that. Spectrum allocations, we are working for communication. And in the software engineering, we have software design, applications, and software testing. We also developed a patient monitoring systems. And IT and society, this is an area where we find out the IT's impacts to the society and policy. And we have also this math and basic science. So in together, I can say there are 7 broad research areas and which are computer science, data science, you saw, electronic systems, and networking, communication and signals, and software engineering in the engineering side, and others was IT and society and math and basic science. We have research labs in, we call as Center for Data Science, Center for Information Technology and Public Policy, called CTAP, Software Engineering Lab, and High Density Electronic System Labs, and Center for Telecom Research. You can go to those links and find out what are the research activities going on. And to quickly to bring our guests to our selection process and the faculties and the students to our faculty members, all of them are PhD from a good universities from India and also North America and European universities, and with a good publication and experience. And our students, we have an integrated MTech program. Annual intake is 90 and it is through the All India JEE. Our MTech program, annual intake is 150. It is through again GATE exam, All India GATE exams. And MSc Digital Society, 30 students we take. This is the year we started this program. This is a new program. It is by written test and interview. We have MS by research, intake is 15 per year through GATE score or written test of IIIT-B plus interview. And we have a PhD program, again through the GATE and written test plus interview. And all these MS PhD student gets fellowships, and also the MTech students, majority of them get fellowships from MNCs and the Government of India. This is the achievements of the IIIT-B with respect to research R&D. Published over the last 15 years, 432 papers in the peer-reviewed in journals and international conferences. And also in the Scopus is the one of the body which does the review of all the communities in our academia forum. They found out in 2009 we are one of the best IIIT with respect to the research. Now in R&D project we have completed 30 projects by this time, and also plus 25 projects are ongoing, means it has been started in 2013, 14, and some came in 15, it is continuing, so ongoing 25. So already we have experience of 55 R&D projects. And so it was sponsored by MNCs like Microsoft, Intel, HP, Nokia, EMC, Squared, Infosys, ABB, Siemens, and it's not limited to that. A lot of other companies also sponsor a lot of fundings to us. Government of India projects are there, DIT, DST, MEA, Shipping Corporation of India, and more. Government of Karnataka is also very supportive to us in research and also building this institute. So ITBT, Department of Information Technology and Biotechnology, and the Karnataka Knowledge Commission has also sponsored projects. We have also international collaboration like student exchange program, collaborative research with different organizations across the globe. This is the thing which we want to tell you, last 3 slides, where we want to pitch in with our collaborator in medical science and also the corporates. Okay, let me start with the medical domain knowledge, which we have been talking to some of them here listed. St. John National Academy of Medical Science in Bangalore, our NUHM, we have been talking and discussing. Narayan Hridayalaya, Indian Institute of Public Health in Hyderabad, Foundation for Research in Health Systems in Bangalore, Center for Budget and Policy Studies in Bangalore. We have some of the already initiation have been taken by my colleagues, and they are talking mainly to get the domain knowledge from them, what are the things they're doing, or they're interested to work with us with respect to technology. Possible collaboration we have with the corporate R&D and Government of Karnataka and GUI, these Intel, Philips and Siemens G, and not limited to all these companies we have been talking, and some of them are already working with us. And Government of India's like ACRB is ready to fund some of our projects. We have already discussed, we went to Delhi, presented to them and already discussed. They are telling us that please start the collaboration with the medical science people and send us the proposals. And also DST and also DIT. And Government of Karnataka, we are talking to ITBT, Health Department, Women and Child Welfare. So these are the quick last 2 slides which I'll show you the areas which may interest you to start collaboration with my colleagues who have been working on this. And this is only some of them I have given, but a long list we can send you later on. The medical imaging, Dr. Neelam Sinha has been working with the project with NIMANS, and our control of health record, Dr. Srikanth is working with the sponsored project. Monitoring of elderly and mentally depressed persons by image processing, Dr. Dinesh Jagup is working. Robust supply chain design, this is supply chain design for the nutrition, Dr. Prasanna, he has already received a very prestigious award from the Government of India for this project. Assembly technology for the biomedical devices by Dr. Madhav Rao. So analog and mixed signal VLSI, very large circuit integrated, this is by Dr. Shubhajit Sen. 3D printing for medical devices, Dr. Srikanth. And data visualization by Dr. Jaya Esnai, she is working on this project. Software architecture and reliability, Dr. Sujit Chakraborty. Techno-economic study by Dr. Shridhar. Body area network by Dr. Tricha, Babat and myself. So if any of these areas you are interested now, so you can talk to my colleagues, all are here later on in the lunch time. So with this, let me stop at here with a vision that IIIT-B is being a institute started as an information technology. Now it has been spread to 7 research areas, and my colleagues are interested to start this research center, which is called EHRC for medical health for the citizen. Thank you again, and welcome to this event.
Thank you, Professor Das. The E-Health Committee has been driving the large agenda for IIIT-Bangalore to actively engage in applied research in healthcare in India. EHRC is an outcome of this agenda. Professor D.K. Srikanth, on behalf of the committee, will speak now on the vision and research objectives of the center.
Good morning and a very warm welcome to all of you, to all the esteemed panelists, guests, fellow faculty, students and others who are here to help us launch this event. It's an honor and a privilege on behalf of the faculty, the institute and the E-Health Committee to welcome you all here, and thank you for being part of this occasion. I'd like to just spend a few minutes walking through kind of our thought process in getting here and what we are looking at as we go forward as part of this E-Health Research Center. Some of it may be quite obvious, but maybe it helps reiterating some of this. When we look at the status of healthcare in India and juxtapose that with the progress of IT, we are struck by very stark contrasts. India is in a leadership position in IT, various figures of 55% of the world outsourcing in IT happens in India. ICT, information and communication technologies are making impact and are permeating more and more avenues, aspects of life that we take for granted, whether it's booking railway tickets, bus tickets, taxis, the way we communicate, starting from voice and SMS to WhatsApp, Skype, the way we order food, the way we order even jewelry, and these are permeating everywhere. And interestingly, these are not restricted to only affluent groups, educated sections of society and so on, but are becoming more and more mainstream. And not to forget the government services, e-governance and government services that are being rolled out through the internet, mobile and other medium. And on the other hand, if you look at health indicators, various bodies that have measured and reported these give us a pretty dismal report on these things. The UN Millennium Development Goals of 2015 has classified India as making very slow progress on most of the health and nutrition indicators. Maternal mortality, infant mortality, and a whole host of other problems are endemic in this space. And while the country has made progress in even reducing in economic development and reducing poverty levels significantly, healthcare indices have not kept pace with this. So this is the paradox we are trying to grapple with. We are an IT powerhouse and have found ways to leverage technologies in diverse areas, but are struggling to harness these technological capabilities to improve something basic like healthcare. Admittedly, healthcare is a very complex system. We should be careful not to trivialize it and simplify what can be done. Its delivery and effectiveness depend on a whole host of issues: medical practices, infrastructure, the problems of scale that India presents, the variety, economic and social variations, environment, government policies, and last but not the least, substantial technological progress. So what here we do at IIIT, the way we have looked at it is, while we fully acknowledge the complexity of the system that we are trying to grapple with, and the enormity of the problem, we are looking at how we can address to contribute to improvements in this area and to solve some aspects of this paradox or incongruity, a developing economy with significant tech progress and lagging health indicators. We believe ICT has a role to play in improving various dimensions of healthcare. As we have heard, this is the 16th year of existence of IIIT. In fact, today is the foundation day, which we celebrate later in the day. And on this occasion, we are embarking on a unique, strategic and research-oriented agenda on using research for IT in healthcare. So very simply put, our vision is to set up a center of excellence in applied research on e-health, which will focus on specific areas in the health domain. We want to build long-term partnerships with other stakeholders across sectors, and our goal is to establish IIITB as a leading research institution that leverages ICTs for healthcare in India. A long journey, but we start today, and we start that with the launch of the eHealth Research Center. So how did we get here? Why are we doing what we are doing? Why are we qualified to even talk about this? You heard a bits and pieces in what Professor Das just talked about. It basically started with the realization, or should I say belief, that there is a need for better deployment of ICT solutions in the sector, and that would complement many of the other ongoing developments there. At the same time, we also believe that we as an institute can focus our energies to leverage these capabilities better and help development in this area. So just like we have seen in other areas, we believe ICT can dramatically transform portions of the sector, making, as an example, collection, aggregation, analysis of data, which is so fundamental to health planning, healthcare, health delivery, providing doctors with better quality, timely information, being able to do develop predictive mechanisms that will allow proactive treatment and proactive care, and obviously monitoring, tracking across distances, across age groups, across demographic groups, and so on. We also realize that the problems are complex and multidisciplinary in nature, even within the technology realm. And as we just heard from Professor Das, fortunately we have a faculty team that spans the whole range of these technologies and are involved in many cutting-edge research, all of which we believe are relevant to healthcare and healthcare issues, starting with electronics, devices, sensors, communication, IoT, data management, data analytics, image processing, visualization, 3D printing, machine learning, mobiles, cloud, software architecture, engineering, and computation in general. All of these are areas where we are actively involved in, and the goal is to see how we can bring this all together. And incidentally, we are not just a pure tech house. We also have a team of faculty who look at the impact and interactions of IT and society. The Center for IT and Public Policy that we run, staffed by researchers with backgrounds in economics, social sciences, management, and others, looking at areas of public policy and assessing impact and effectiveness of various programs, technology-enabled social programs that get rolled out, whether it's e-education, e-governance, education, healthcare, and so on. So while we are relatively new to healthcare, we have made a start and want to make a bigger push in this direction. Many faculty have already worked on projects in this area, and as we heard, as we speak, proposals are being developed for new projects in this area. We also fully understand that the topic of healthcare cannot be seen from the silo of a technology or a technology perspective alone, nor can a technology institute such as ours make any meaningful impact working in isolation. We know we need to partner with other groups and organizations, hospitals, doctors, government agencies, social organizations, technology providers, and so on, so that we can create comprehensive, deployable, and sustainable solutions that will make an impact. Luckily, as an institute, we've always been very proactive in pursuing partnerships in various areas that we work on. And today, even for the eHealth Center, we are actively reaching out to various organizations, government and private, for partnerships and sponsorships, and where we can play a technology partner role. We also realize that anything in healthcare is going to be long drawn, is going to take a long time to make an impact, and accordingly, we are planning a research as multi-year programs and not short projects alone. So this is not something completely new to us in a different way. As I said, we have focused on looking at the impact of technology and how it interplays with various other aspects of society. As was briefly mentioned earlier this year, we launched an MSc program in digital society, a kind of first of its kind program in the country, which trains students in understanding the digitally connected society in all its facets, and in looking at its many interfaces and constituents. On another track, about a year back, we initiated a Center of Excellence and Accelerator program for mobile and IoT applications, where we work with startups who are looking at the areas of health, governance, education, and so on. And actually many companies have been going through the accelerator, and some of them are here in our audience today. Of course, we also have a thriving incubation program that's been going on for about 9 years, and some of these have focused on the healthcare space. There are companies here, for instance, who have developed non-invasive diagnostic care for diagnostic devices for remote care. So the mission, if you have to paraphrase it, is that we're looking at how cutting-edge research on ICT technologies can meet the healthcare needs of underserved segments and marginal segments of the population of countries such as India, and hopefully extend that to the rest of the world later. And we want to focus on a few aspects. We're looking at solutions that will improve affordability, accessibility, and availability of healthcare. And from a technology standpoint or a solution standpoint, we're looking at solutions that will cover medical devices, data of various kinds, and delivery platforms and models itself, what we internally call the 3 A's and the 3 D's. So accessibility, affordability, and affordability driven through data, devices, and delivery. So we plan for the center to be organized as multi-year interdisciplinary research programs along certain themes that we have identified initially, and which we, through our collaborations, hope to refine and improve on as we go forward. With, like I said, with strongly with external partner organizations in industry, academia, and government. To provide some synergy and initial starting point for our programs, we have identified 3 thematic areas which will be the initial area of focus. We have identified malnutrition, mental health, and disabilities are 3 areas that we'll focus on. And within that, focus on solutions that would be relevant to children and senior citizens. Healthcare is a large space. We looked at all the different activities we do, and we are able to find synergy or some critical mass in these areas. And these are, like I said, at the starting point. Over many years, we expect it will expand to a much larger spectrum itself. And there's no question that these are areas, if I look at malnutrition, mental health, and disabilities, they are in areas in need of attention, just like a lot of other areas. I think I don't need to elaborate on that too much. And consistently, we find, irrespective of the areas we look at, that elderly and children are severely impacted by pretty much any area, including mental health. So while we look at these, part of our research also involves developing technological aids for improving quality of life for people with visual and locomotor disabilities and for senior citizens. From a technology standpoint, looking at the breadth of technologies that we work on, we are also developing certain what I'll call horizontal capabilities, horizontal platforms, research programs in the area of software architecture, Internet of Things, low-cost sensors, 3D printing, multimedia analytics, visualization, and so on. And these will be the bedrock on which we start developing segment-specific solutions. And we had seen a list of projects. Actually, there are 18 of our faculty who have come together to contribute ideas, proposals, and are already engaging in something and some aspect of this, work in this area. They'll form the initial team of the research center. We'll work with others within the institute and outside to set up these projects, solicit funding, and guide research in these areas. We are looking at a variety of funding agencies, government departments, foundations, corporate sponsors who will partner with us to support these activities. Obviously, as a research institute, as an education institute, in addition to these solutions, these programs will help train masters, PhD, and other research students, and generate specialized courses and programs in the area of e-health. Just like we introduce something in digital society, maybe in a few years we'll jointly develop a program on e-health. So we start this ambitious journey today, start with small steps, baby steps, but with big ambitions. We'll start by soliciting input, as I said, in the panel discussion that we'll have right after this. Will give us inputs on how we can start framing a research agenda for this whole area. So once again, on behalf of the Institute, the eHealth Committee, I would like to thank each one of you for participating in this event, for the support and the guidance that you're providing, and we hope will continue to guide, and we look forward to fruitful collaborations with all of you. Together, we can try to make an impact on healthcare in India. Thank you very much.
Thank you, Professor Srikanth.
Now we begin the highlight of the event, which is the panel discussion on information technology and healthcare needs of an emerging India, framing a research agenda for e-health. We're grateful to the panelists who are eminent experts in their field to take their time out to join us and give us their insights on this topic. The expert panelists today are Dr. P. Satish Chandra, Director of NUHM, Dr. Devi Prasad Shetty, Chairman of Narayana Health and a renowned cardiologist, Dr. E.V. Ravana Reddy, Principal Secretary at Department of Personnel and Administrative Reforms, Dr. T. Rajeshwari, Consultant with Quality Networking of Professional Education at Rajiv Gandhi University of Health Sciences, Dr. Niranjan Tirumale, the Chief Technology Officer of the EMC India Center of Excellence, Mr. Shivan Menon, CTO Software India GE Healthcare, and Dr. Nirmala Murthy, Mentor Advisor at Foundation for Research in Health Systems. The moderator for the discussion would be Professor S. Sadgopan, Director of IIIT-B. We would like to invite the panelists and the moderator to take their seats on the dais.
Good morning. So on my behalf, let me once again welcome you all. And I think 6 of the panelists are already there, and Dr. Devi Shetty should be joining any time he has left. And without spending much of the time, let us kind of start. So my job is very simple. One is to the stage has been set. So I'm going to kind of ask a set of questions, and you all can give your perspective. All of you can decide to give, or maybe some of you can give. So roughly about 10-15 minutes, that will take us about an hour, and then we will have time for the people in the audience to kind of ask questions. Just to make you all feel comfortable, there is no press. Okay, so it's important, right? Okay, there is no press, we can be. And one request specifically to you is, we are starting with an absolute clean slate. So we really want you to give critical inputs. And because every one of you have some intense experience in this kind of area, and I think what I felt humbled, in fact, Dr. Jaya Nair, who was actually doing all that, I call her the Sutradhar because she stands behind and pulls all the strings, but you don't see her, okay? She's sitting there, and she came up with some names, and exactly one mail, everybody said yes. And you see, Dr. Nirmala Murthy is very special because she has been calling me for so many meetings in the last 12 years, and out of the maybe some 20 times, maybe I did exactly once. She's still not upset with me. I'm grateful to you, ma'am. Thank you. And she's one person who has been looking at it. And Dr. Rajeshwari and I, we did a program many years back for a BBC, and completely lost touch. But one email, she said, yes, that's it. Okay, so grateful. And particularly for students, I want you to know that this gentleman, we are all sitting here thanks to him. Okay, this building we got from somebody, don't ask me what, okay? We have to give a check for them, and this person was transferred on that day as a director of IT, but he waited the whole day, got the check. He always comes to me, he never bothers me, and that day he said, sir, please come to the Vidhan Sauda. There was no Vikas Sauda at that time maybe. And I went to Vidhan Sauda, picked up his check, he handed over the check, and then went and joined other department. And that's why we are all here in this one. Grateful to you. And he used to be the health secretary. And he said, maybe you should call the new health secretary. I said, I don't know the new health secretary, but you have lots of insight, because we are not really going by tags, we are going by insights, and he has lots of it. And of course, Dr. Satish Chandra has been helping us in multiple ways. Professionally, he has been interacting quite a bit. I'm sure many of the students would have benefited from his talk. And again, in spite of being a busy NUHM director, he once again said yes in kind of no time. Dr. Shivan from GE, see, the choice was something like this. We need, because our home is technology, so we said we should really look at the technology companies. Obviously, GE, Siemens, and Philips, these are the 3, and and Intel, EMC. So we kind of looked at some technology companies. We wanted the medical college, we wanted the 2 premier institute, the NIMHANS and Narayan Hridayalaya, and there is one person by Dr. Nirmala Murthy who has kind of looked at it for fairly long time. So we said we should have a full perspective. That is how the panelists were chosen. And here Dr. Shivan represents the GE. And of course, many of you would know that Dr. Niranjan has been coming and we have been participating a lot from the EMC side. Okay. The first and foremost is a very simple question. Whoever wants to take it first, we're perfectly fine. Tell us as blunt as possible. Okay. Has ICT delivered anything at all in health domain? And preferably from your own personal experiences. So is it all nice thing which we talk about, or is it something we genuinely added? So you want to take it up first, man? Has it delivered? Be brutally honest. If it has not delivered, tell us.
No, I don't want to tell you.
Okay, fine. Okay. Whoever wants to take. Yes. Okay, any one of you. Yes.
Unfortunately, neither am I the right voice. I've got a hoarse throat, so excuse me if I'm not clear.
No problem.
But I'm also a voice of negativity because I say no, it has not delivered its potential. There is a lot of potential. We've seen how it has revolutionized a lot of industries that we interact with on a daily basis. Telecom, banking, travel. But healthcare somehow has held up. And there's a lot of promise. Professor Das spoke in his earlier address also that how it is that despite all the promise, despite knowing where the problem areas and what is it that we need to cultivate as a solution, it has not come together.
Okay, please. Yes.
I'm an end user. I am on the other side where the technology you provide. But I don't say that technology has not provided anything. Definitely information technology has given us many things, but we expect more like any other field. So we are never satisfied. As an end user, we are always looking for something more, something which we can use it. In that area, with our problems and the population which we have in a country of 1.2 billion and having a population problems, especially in relation to our educational status, we have a problem which cannot be reached so easily. And hence, the technology has to replace this. And the technology has to overcome many of our deficiencies. The deficiencies could be in the form of manpower, deficiency could be in the form of cost cutting, or the deficiency could be in the form of the newer technology and newer devices which are required for dissemination and also for the research. And for such things, definitely the technology has helped. But whether it has reached the potential, the question which you have raised, definitely not. Okay. It has not reached the potential, it has many more things to contribute.
Thank you, sir. Before I give it to Dr. Raman Reddy, I am an incorrigible optimist. You all remember the 101 marketing course where somebody went to an island to sell the shoes and there was just nobody wearing the shoes. And they said, look, there is just no way because this particular tribe doesn't seem to believe in shoes. And the next person said, no, I have the 100% of the market share is with me. So in some sense, if you have not delivered, there is a lot more opportunity for us to deliver. So I take it as a positive. Okay. Dr. Raman Reddy.
Yeah, Professor, as you said, I was Secretary Health in Karnataka for 3 years. Definitely, yes, it has not delivered to the potential, but immediately when you said, I remember 2-3 initiatives which were taken using ICT in health during that period. Right, we had one program called Mother and Child Tracking System. This has helped a lot in Karnataka to improve the IMR, MMR and institutional deliveries during that time. And in fact, we got some international award also for this Mother and Child Tracking System. Basically what it used to do was, right from the day somebody knows that she got pregnant, from that day to delivery, 2 to 3 years of the child's age, immunization and everything, the ASHA workers are the, not the government employees, but the health workers who are paid some incentive under the, at that time it was called National Rural Health Mission. So they were given the mobile numbers of the expectant mothers and ASHA worker could track that mother and child till at least child became 1 year or 2 year old by giving immunization at right time, by calling her to the hospital. Even we went up to a stage where 108 driver will call the lady and ask whatever is the due date, he will ask her whether she will be willing to go to the hospital. So this has definitely increased the IMR, MMR and institutional deliveries in Karnataka during that time. Now I hope it was continued and definitely it must be helping us. Other thing which ICT really helped us was this human resource management system. We have thousands of, in the government setup after the education, I think then police department, third is the health department which has the maximum number of workforce in the government. So in tracking these people, in having a database of all these people really helped us in placing them in different places through counseling. And another one thing which helped us most was HMIS, Hospital Management Information System. That way definitely ICT has helped the state in the health sector, but as everybody said, we may have to, that may be 5% of what we could have done it. So maybe 95% is there yet to be exploited.
Thank you.
I would like to add and say that though Dr. Satyendra said that we were the end users, but ultimately the fault lies with us also, because we physicians, the manpower who is supposed to utilize the technology, they have failed to accept the new mechanism, making a break or acceptance of a new policy. Because it is these people who should come forward to implement the process. Initially, of course, there are a lot of hurdles and problems that one will face. It's not the administrators initially who should initiate, but it is the physicians who got to accept the new trend, and those are certain areas which are lucrative, which are incentive based. Those are the areas that they look at investment, let it be a hospital or let it be another sector or clinics for whatever policy where this new technology comes in. Everybody has to face through the initial teething problems. So naturally, if these things are cleared up, I think once they understand the value of the high returns of what one can get by a short interval of implementation of this, I'm sure we're going to work wonders, and the time is not very far. I'm sure with all of us going at an aggressive pace, we are definitely going to result in a good performance of our IT sector in healthcare. Thank you.
Thank you.
Thank you, Dr. Shadgopal. I said no to starting because I am the oldest by age, experience and number of failures at my credit. And I am also grateful that you publicly acknowledged that you were invited 20 times. So I stand 19 visits from you.
Yes.
Now, in terms of, as I said, IT, if we didn't believe that IT technology was of no use, we wouldn't be here looking at this issue again and again for several years. I also know, because I started doing work this in 1980 when the microcomputers were coming and there were no laptops and so on. The one thing that doctors did, and I agree with you, there is a mental block that we all doctors had, because we used to say, well, if I knew IT, I would be an engineer, not a doctor. That's the first hurdle. So to get IT technology dealing with doctors is a problem, and it's something going to be a major challenge that we would have to face as we go further. We also expected, working in this, is that people expect too much. They think once there is a ICT, there is a computer, there is an information system, it's going to solve all my problems. It is going to deliver all babies. It is going to make sure that everybody is not malnourished. So the part that ICT technology only helps you and doesn't do work for you, that takes a little longer to see in our way. Now, where I have found in so many years, my work has been in the area at the field level, reducing the drudgery of data collection, data reporting, data transport, data use from the primary health center down up to the level. That is where I have spent all my life, and it's smaller successes. And what I found the ICT does, one is of course if you are able to reduce the drudgery, and that of course technology should help, and it's a challenge that I would like the center to focus on.
It's easier. Yeah, easier. Please go ahead, yes.
Improving accuracy of data. This is something that I realize in the field, that there is a tendency to change data. First thing, when we first started writing age, over time, that if you write date of birth instead of age, then it automatically changes. Even that idea wasn't there with us for 20-30 years ago. And so even now when I go to a laboratory, I am 5-6 years later, I'm still age 63 in my laboratory records, because they have not changed. And that's even the little thing that you put a date of birth rather than age will help you over tracking. That's something that we have learned over time. Also, people tend to change data. Whatever is convenient, you change data so that it stops from doing it. But one thing I learned in the field several years ago, that first time when we were used to carry these printed names of the women, whether they are registered for pregnancy or not, women in the villages will come and see my name is there, and say, oh, it is not there, put it. Now that's when I realized the name of the person brings accuracy. Name of the person creates the kind of linkage with the service, and names bring some kind of involvement of people. So what I would like, going forward, is to realize it's not analysis of the nice visualization. They're all important at a policy level, but linking the people with name, their personality, themselves in the system, that brings in doctors to use the system. And solving families, the saving of time. So what we have found so far, the failure we have found, is that it takes a lot more time now than it used to with the paper system. Paper system I can modify anywhere. It's like a tax reform. Every time they talk about simplifying the tax forms, and they become more and more complex. It takes more and more time, and I need also the auditor. So that's another thing, that how do we actually really simplify to see that people save their time.
Thank you. So thank you. Niranjan?
Sure.
Yeah, please. Yeah.
Yeah, as opening question, I think we will be spending time on this, right? So I have two slides to this, right? There are two people sitting on either of my shoulder. One of them looking back at what has happened in healthcare and IT, and comparing it with what has happened in other domains, and acting very disappointed. That so much could be done, but nothing has been done. It's not taken traction. It's not been effective, right? So I think Professor Srikanth talked about 3 A's and 3 D's, right? I think I'll add a couple more things to the alphabet soup, right? If you look at what IT has done across, historically, it's done 3 things very well, right? One is it's brought in efficiencies, right? It's cut down on a lot of drudgery, as Dr. Murthy said, and brought in efficiencies into the system, and that is something that healthcare absolutely needs. The second thing it has done is it has the potential for cutting down errors by removing a lot of the manual stuff that could be automated. It cuts down errors. And if you look at medical practice, I think Dr. Shetty was here, he would echo this, is that cutting down errors fundamentally improves the outcomes, right? And errors are very, very common whenever there are people in it. And the third E, I would say, is that IT has brought about new experiences. New experiences in the way you deal with the providers, the industry, and so on. So I think those would be attributes that I would add to that. And the optimist in me says that don't look backwards. The time is right. Right? The time is right from the perspective of new technologies, technology trends pointing towards a very near-term transformation in the healthcare industry. It's not 20 years away. It's reasonably close. So I'm very hopeful.
Okay, thank you. That's it's always good. Okay, so let me kind of switch the question. Switch to the next question is that yes, we do have a certain amount of mixed bag in terms of the record of the past. Obviously, there is much more of optimism in the future. Maybe I will start with you. A whole range of things India can do. Okay, so at this point in time, the center, we are trying to focus on India-specific problems. Of course, there are lots of things are happening all over the place. We will always learn from them. But with respect to catering to the Indian consumers, population, and of course it could be the end users, obviously, but it could also be serving the hospital, serving the health center, serving maybe all the people in this ecosystem. If you have to take a priority, okay, tell me 1 or 2 things which we should really look which probably would give us some inputs into how we should focus in the next 5-10 years as far as this center is concerned? What are the 2 or 3 things which we should kind of focus on?
Great question, Professor. And here, some way to think that that the thought that I'm going through with this thing is one is the use. I mean, there are multiple users, right? A very primary user is the physician, is the doctor, right? And if the medical fraternity doesn't embrace IT, anything that you do outside of that is going to be very hard to create outcomes out of. So, and I think fundamentally why we've not succeeded in doing this properly in the past is that we've not created value for the medical professional in using that IT, right? If you say health records is that value, I would disagree. They would need to be a lot more given as a personal value to that person, to the doctor who's using that. Otherwise, they will not use it. And this is true in general. There is no incentive for people. So I think one of the ways we can target research, or one of the ways we target things, is to actually get that hook. What is that hook? What is that additional value that you can give to the user for them to use it? Because until you use it, you're not going to start iterating and making things better and better. Right? So so this is not something concrete. I think there's more of a thought as to saying that value that's directly perceived, it's value that's not hidden in a layer somewhere, right? I think that has to be done. And given where India is today, right, and the government does a lot of focus on maternal and child health, right, and that is the primary focus when I talk to any of the government people. You go to PHCs, you go to the policy definitions and so on, maternal child health is primary importance. But I think while that is great from an MDG standpoint, I think we are ignoring the larger things of non-communicable diseases and so on, right? So how can ICT start looking at diseases that need to be managed as opposed to cured? Things that have to be cured or things that have to be operated upon, I think there is less scope for doing things. But things that have to be managed, maybe there is something that we can do.
Good. So maybe what I'll do is this, on the same question, if I can kind of flip it a little bit. One set of people said that, look, we don't do medical devices at all. Maybe it's time we do medical devices. Other set of people say, no, medical devices, the whole world is doing. Let us kind of focus on data because that is what we seem to be doing very good at. Okay? What would be your take on it? Should India really focus on medical devices, sensors and medical devices?
I think they definitely are part of the play, but the value that they bring is the data that they contribute. For instance, without the devices, you can't gather the data. So I just leave it there.
Right.
Getting back to this problem and continuing from where Niranjan left, or if I may jump in there. I think we kind of at a stage where we're pretty much greenfield. We've had, like Dr. Reddy said, we have a number of examples of good demonstration of ICT, but the problem is that they have never scaled, now been replicated across care areas. And the real challenge is to be able to get the momentum, get acceptance across the user community, get acceptance across the ecosystem that needs to use it, so that it can automatically then become something as a way of practice, and then it can be replicated across. To do that, first I think we need to come to basics. We need to ask that question. Why is it that the users don't want to use it? And my personal experience tells me that it has got a lot to the way we design data systems, data interface systems. If you don't design with the user experience in mind, if you don't design with the workflow in mind, if we don't look at the problem or the care pathway holistically, we will do piecemeal design, so that there would be, at best, there would be half-hearted adaptation of this. And we all know that garbage in, garbage out. So the data doesn't come in properly. Anything we attempt to do subsequently will be of no use. So I would imagine the first way would be to figure out a unique manner in which, for our ecosystem, for our environment, how it is that we can devise user experience driven software solutions that can help users automatically adapt. It has to solve for very specific problems. We have several issues that stop us from using it. We have to specifically design for those. If we do that, it's like kind of laying the road, laying the highway. We can then subsequently quickly bolt on a number of technology-driven solutions that can then demonstrate real power of it. So my 2 cents would be we should focus first on building that adaptability.
Okay, so building the basic stuff. Dr. Satish Chandra, if I have to ask you this question, like you have been very kind, you have been visiting us for the last 2 years. I'm sure as you drive back, you must have felt, I wish these guys do something for this, but they guys talk, they don't do. What are those things you wish an institute like us, if we have done, it would have actually given you some sense of confidence that, something got done? Your wish list.
It is a very important question which you have asked, and as other end where you are talking about the mental health and disability, where I come from, and we have a lot of wish list in that way. The mental health is one of the neglected area, which is neglected in all respects from the government side as well as from the user side, and both have problems. And to bridge this gap, I think the technology plays a very important role. And we need to know, we have started in a one way I could start from. We do not know the magnitude of the mental health problem in this country. That is the first and the foremost question. Everybody has got their own estimate, and the estimate is very vague. For that, we need to have a survey from that angle and the data collection, and wherein we embarked on National Mental Health Survey now. We have been given an opportunity to do a national mental health survey for the whole country level. And we have started that, where I felt the technology plays a very important role in collection and as well as retrieval. And we are using now a tablet system where it can be taken to the periphery. But we know that there are a lot of lacunae from the collection and then transmission and then retrieval. There is a lot of gaps, and we are facing that problem at every stage. And maybe now we are compounded further by the present system of mobile technology which we have now. Still it has got a lot of problems. We have gone up to 4G, 5G and whatever it is, but we are now having a lot of call drops and all sorts of things which have come up, and which is further worsening the situation rather than doing good. Whether our base was at a defective level, which needs to be addressed too. That is one of the important things where the data has to be collected. The second important aspect in mental health issue is the awareness and the stigma which is there in the society. We may shout from various forums, whatever we have, saying that this is a curable disorder, it is a preventable disorder, all sorts of things. But I'm sure we cannot even reach, not even 1% or 2% of the population. So how do we reach out? Reach out to the periphery and reach out to the masses is only through the technology. And where we require your help to have a platform or a portal system wherein creating awareness among the public is very much important. And mental health is one area where the stigma is very, very high. And unless and until we bring out in a simplified way how we can reach out the periphery by bringing this technology into the forum is one important thing. I can say that we have started. We have started with a small foundation in our own institute, wherein your colleagues like companies like Mindtree has entered, and we have a foundation called White Swan Foundation, where we are looking from a platform-based technology to portal to get into what can be done in creating this awareness and what level it can be taken to. That is the second area which we are talking about. As we are talking now about the electronic devices, friend has asked about devices and sensors. This is very, very important. We know the policy of Make in India or the Digital India, but we talk about it, but what we have achieved is very little. And we require a lot more there. That can be done, and our own examples of what we have done in our own institute is starting a simple sensor, sir. A sensor which can detect the pressure inside the brain, which is called an intracranial pressure monitor. And this technology can be developed very easily within our own reach. However, we import the technology and we pay a lot of money for that. That is causing a lot of problem. But the technology is available. where it can be translated and used. The same sensors and same technology could be translated into medical field. My friend is here. He's already there. We're talking about, I don't know how many times I discussed with, we have a GE, we have the Siemens, and we have Philips. Each one produces one technology, and then we get into the user system. I have one machine which is made from GE, another machine made from Siemens, another machine made from Philips. But as an end user, I want to compare. I want to have the image solution system which can read all the three together and also have a comparison. It is not possible at all. Each one comes with a different technology, and wherein we have landed up in trouble. I have one from this machine and one from that machine. According to them, we are cornered that we have to buy the same thing in future also. No, I don't want to do that, because they will become the proprietary items, and after that they dictate the terms to us. We need to have a choice. But when we have a choice, can we use a solution or a system for image processing wherein we can use all the things together and get the data out? We have image processing, we have some things developed our own, but still it is not up to our expectation. That is the other important area where we can use it. Then the next point I would say about the health delivery system, as well as when we have shortage of manpower in this country. Can we use the technology to reach out to the periphery? We have some experience. We started a system called Virtual College or Virtual Knowledge Network. And through the NKN system, what we have, and we have started a VKN system. And a Virtual Knowledge Network, we are able to now reach to the periphery using the smart technology, and so that we can transfer our classrooms, what we have here, to anywhere in the country or anywhere in the world. And now it is possible even on a mobile phone, and a mobile phone is being used, and that could be, now our lectures are all being translated various places. And that is the only way we can think of reducing the manpower, because which is a shortage in our country. Then the last one which I wanted to use is, can we use the mobile technology as well as the GPS technology combined together, which has, if you combine together, has many things which we can innovate, and innovations which could help the people to solve many of the problems. For example, if you have this mobile and the GPS technology which could be combined, we require people to be identified. In a mental health issue, there are many people, for example, an elderly individual is missed, and the family is always worried about where that person is lost. Can we have a GPS along with mobile technology? Could be given in a form of a simple band, and that band can transmit the information to us and or to the family, which can trace the thing. Or some paroxysmal events. I'm sure Devi Shetty, if he were to be there, he would have mentioned about the heart ailments which is there anywhere in the world. Or being a neurologist, and also epileptologist, I look from an epilepsy point of view. A patient is found on the road somewhere, and we do not know anything what has happened. If somebody is found, and that band could help the picture as well as transmit the picture, as well as what can be done. And we can deliver the things there. That is another area where I require the help from looking at these paroxysmal disorders, which can occur at any time, bolt from the blue, wherein the technology could help rather than I cannot station the people everywhere to look for this. So these are the areas I think that we can look up and also see what can be done.
Thank you, sir. The lots of students are listening, so I'm sure that they're getting some ideas for projects. So thank you so much. And so to make Dr. Ramani Reddy's life little miserable, so let me kind of provoke him. Okay. So he has been such a good friend, so I can take the liberty. See, a lot of times, you in the government, okay, so lots of things are purchased, from the vendors, okay. See, quite often you find the only way by which you can kind of force the vendors to share and get into non-proprietary stuff, this is something done all over the world, is for the government to insist on some standards. Okay, do you think that something like that is doable in government of Karnataka? Because we have an advantage, because we are a technology capital, and all the major medical equipment vendors of the globe all have just not presence, strong robust, deep presence. Okay, GE, Philips, and Siemens. Okay, so do you think something like that is kind of doable in the next couple of years? You know, have some kind of a crack team. Just look at it, and at least the government purchases and government institutions will force a certain amount of emergence of a standard so that things don't get locked. Okay.
Yeah, definitely, Professor. Actually, in Karnataka government, we have what is called Karnataka Transparency Public Procurement Act. So where not only tendering is compulsory, but whatever we purchase, we have to set up one technical committee. It has to set up certain standards. Then we have to go for qualifying the bidders. Then only we go actually for the financial bidding. So definitely some procedures or some systems are already there. And in the medical field also, maybe major hospitals, maybe doctor will be able to tell you, like BMCRI and NIMANS, J.V.R. Institute of Technology, all these major institutes of government of Karnataka, definitely they must be following it already. And definitely, yes, it can be further improved upon. In fact, 5-6 areas I wanted to mention, Professor, because though my name as a doctor, I am not a medical doctor, I have a PhD, so I cannot be, my suggestions may not be from their perspective, I am not technical perspective. But as I mentioned earlier, I worked as health secretary in Karnataka for 3 years, so I felt, because I saw the brochure where it is said mostly you want to concentrate on applied research, I felt there are 5-6 items which I can mention to you. Firstly, Professor, if you take Karnataka, in fact, South India is far better in the health sector compared to the other parts of the country. Within the South India, naturally Kerala is smaller state and highly literate state. If you leave out Kerala, Tamil Nadu does far better. Karnataka is not doing that bad, but it is also, as I said, South India is better. Within South India, Kerala and Tamil Nadu are better, but otherwise, health indicators wise, Karnataka is also doing better. But everywhere, whether it is in the North India, South India, the main problem is the manpower. The specialists, especially the MBBS doctors, are available in plenty, at least in Karnataka, because we have more than 40. At that time when I was in health, we had 40 medical colleges. But specialists is a problem. In fact, North India, there is a acute shortage of, even UPBR, 80% shortage of specialists in government sector, which may not be that bad in Karnataka. So with this background only, in collaboration with Dr. Desiraju Narayana, we have started telemedicine at that time. We have set up telemedicine centers in all the district hospitals, and we had referral centers in NIMANS, J.V.R. Institute of Cardiology, Narayana. But after some time, at that time, maybe this is 5-6 years back, connectivity problem. And one major problem which I felt with doctors was mainly ego problem. He doesn't want to say that he doesn't know. He doesn't want to ask somebody else. Then he will feel below his dignity that he has to consult a higher physician or higher specialist. So somehow it worked, but I feel that it won't lead us to what we expected. So this may be one thing, Dr. Telemedicine, how we can use telemedicine. Now internet connectivity is so much that we have 4G connectivity. If you see the Airtel ad, one movie can be downloaded in few seconds. In fact, I was remembering, when if you want to make a call from here to even Washington, these days speed dial is there. If you press a button, within seconds you get the call. When I entered this state, I was a probationer in Karwar. Karwar and its taluks didn't have what is called STD. Maybe students who are students here may not know what is STD, because at that time it is called subscriber trunk dialing. That means you can press the button and it will go. It didn't have STD, so you have to ask the operator to connect. I remember that it used to take 4-5 hours to get connected from a block in Taluka in Karwar to Bangalore. So that was the position. Imagine the systems there, then and now. So we have so much technology upgradation, definitely we have to make use of it. Secondly, as mentioned by one of the panelists, Professor, whatever you may do, ultimately when somebody comes to Karnataka, you say, what is your IMR, what is your MMR, what is your sex ratio, what is your life expectancy. So I feel fundamentally, as mentioned by the panelists, something we have to do using ICT, as I said, MCTS, mother and child tracking system, we were using it. Now also it may be there, I am not in touch with it. But something we have to do to improve IMR, MMR, that should be the major focus for this center. Thirdly, doctor, as you said about the medical equipment, another biggest issue in health sector is drug supply. Drug supply, not that we don't have money, we have enough money in government. These days, at least Karnataka government is not in short of funds. But managing these drugs, having them at right time, reaching them to various places and tracking them up, we have some 2,500 PHCs. Whether that PHC has this drug or not. So I started something of a computerization process, but at what stage it is now, I don't know. But that, if you can look into it and do something, I think that will help the population of Karnataka tremendously. That is number 3. Then, Professor, I saw in a brochure about the nutrition and malnutrition. If you remember, a few years back, there was a big problem. There used to be public interest litigation saying that there are a lot of undernourished, malnourished children. In fact, there is what is called SAM, severely acute malnourished children. At that time, we did a survey, there were 60,000 SAM children in Karnataka. Even Gujarat is no better. Gujarat also has thousands and thousands of severely acute malnourished children. We had to do health checkup every 3 months and follow it up and give them some nutrition. This was a major program. But now I think if something can be done, nutrition is part of your brochure also, if something can be done to, now 60,000 may not be there because we have taken up a lot of programs, maybe 30,000, 20,000, 10,000, but some kind of tracking them and helping them in managing these malnourished children, I think that will be number 4. Number 5, one of the panelists has already mentioned, these lifestyle diseases, doctor. I think day in and day out, in future we will have more lifestyle diseases, so something can be done there. Number 6, in fact, I was remembering Dr. Desiraju once when we were discussing, he was saying the life expectancy is increasing so much that Desiraju said, when I am 70-year-old, my father may be 90-year-old and still may be surviving. So I have to manage him also and manage myself also. So what he was, in fact, Prime Minister every time says 65% of the population in the country is 35-year-old. But this is changing because this is not me, but Dr. Desiraju told me that in future, the geriatrics and managing the old people will be the biggest thing and tracking them. Nowadays what is happening is nobody stays with parents. Even I don't stay with my parents. They are in some district in North Telangana state, and many of children may be in US also. Nobody, in fact, that may be one of the biggest challenges in the future to come. Sir, I don't know, may not be now. No. But geriatric care and tracking the older people and giving them some care and linking them up with the doctors. Some apps are already there, I see now and then in the papers, but something to be done there. So I felt, doctor, these 6, from the practical point of view, by working in the health department, I felt these are the 6 issues to be flagged for the health research center.
So thank you, and I think you have given us a lot of homework and we have taken notes. Thank you. And okay, so Dr. Rajeshwari, so you see, as you know, for a long time you are the principal of the Bangalore Medical College. Okay, so maybe your perspective, because you know, as a medical education administrator, you think that in terms of medical education, in terms of, you know, at the MBBS level or at the higher level, what do you think that maybe an institute like IIIT can kind of help a partner, you know, if we have, do you see any value in kind of working? You know, one of the difficulties in India is that for some reason that, you know, most of the disciplines are separated at birth. See, Harvard Business School, Harvard School of Applied Physics and Harvard Medicine are part of the Harvard University. But in this country, okay, all the technical education is VTU and all the medical education is RGH. Okay, so we are so separated, so we don't kind of get together. Is it some value you see in partnering?
So definitely I see a bright future for this type of association, at least with the trend of the present person is on the chair of Bangalore Medical College, who is the director. So I happen to be the director of my own institution where I did my undergraduate and rose up to be the dean. So Bangalore Medical College is very dear to me, and I've lived in that place for nearly 40 years. That is my long link and has made me very strong. And I'm very proud to tell you that certain areas which were to be accepted as a reality came into real force, and that transformation occurred when I became the dean, because I saw the realistic problems when I was an undergraduate, postgraduate, and we had all institutions. We had 5 hospitals attached to Bangalore Medical College at that time. That is Victoria Hospital, Vanivalas, Minto Hospital, and the Bowring and Lady Cousin Hospital, and STS Sanatorium. You know, the Victoria and the Bowring Lady Cousin Hospitals were nearly 1.25 decade, century. So 125 years to 130 years, and you know the government trend when it is under the Heritage Building Act, nothing can be demolished and converted to what you need as modern technology. So as we say, we keep saying we resist, but when we ask, we can't go against the law of the land. And it so happened that we had to maintain the architecture, and that was the way of coming in the progress of the institutions which were needed for Medical Council of India. Medical Council of India was not active when I was an undergraduate or postgraduate. It really became very strong in the late 90s and 2000. And I'm very thankful and happy that they brought in certain standards, benchmarks for medical education. When you're going to experiment on human beings, would be been seen as guinea pigs, because many of the areas people think it's a commercial breeding center for making a lot of money. See, you can make it if you look at it that angle, but ultimately the guinea pig is the population at will. So it so happens when it comes to the government sector, with 3,000 beds under the control of Bangalore Medical College, which was a massive task. But those days, most of the specialties had come up with post-graduation. But super specialties had not come up to the mark, because Medical Council of India will not give you permission if you don't have the structure under one roof. That is, certain norms, because the OPD is somewhere, the wards are somewhere, the labs are somewhere, everything is somewhere. So you can't have piecemeal distributions of a department. It should be under the same roof with certain norms. This is the area and this has to be the way. So I used to be a medical, by God's grace, I was also appointed by the Medical Council as an inspector for 15 long years by that time when I rose to my chair. So it gave me the value of trying to know where I was deficient and where the other institutions were positive. And so it sort of made me feel very bad that having everything, still I was not able to transform my center, which could have been one of the best. And at that particular time, Bangalore Medical College rose to the second position to AIIMS New Delhi. It was the top second best medical college in the state and in the country at that particular time in 2004 when I was the dean. And it remained in the top 5. That was a challenge that really came as a value to the government at that time. It stimulated the government as well. And it so happened the 100 crore project was being given by the Pradhan Mantri. This is not as Pradhan Mantri Swasthya Suraksha Yojana scheme was in existence. And 2004, Bangalore Medical College was in the second ranked position. And in 2005, we had the Golden Jubilee celebrations, for which coincidentally I was also the chairperson of the celebrations. So as a principal, it gave me the privilege of telling my CM and his team who had come for the celebrations, to tell him, ranking the second position, that my government had not initiated it with the health secretary sitting here. I just want to tell you, I was so bold to tell him that with me ranking the second position, nothing is being done, whereas the other states of Tamil Nadu, Jayalalitha had already moved Salem, and the Honourable Naidu had moved Sri Venkateshwara Institute, and I don't remember the CM of Kerala at that time, and he had moved Trivandrum, and they were nowhere in the ranking of even the first 20 those days. And it so happened that when I was ranking second, I was not to be shown anywhere for the development process of what was waiting as a 100 crore project. And really the way and things which happened, I told this here, with only your funds I brought it to the second position, but if you could move it at the center, I would make it equivalent to AIIMS. That was a daring word I put across, and just forgot about it, thinking that this was the end of my story. And really, you won't believe that my CM really acted and initiated the process, and I was just given 2 months, a marathon task to perform, to present the 100 crore project of such a, it was, see, ultimately I had to start with land survey with land sharks usurping some of the land. I did not know the land area under my own institution and attached hospitals. Ultimately, I myself was surprised because none of us who worked for 50 long years at that time ever knew the land under our area, because everybody would pass on the buck. As long as I get my pension, I go safe, let the next person take over. See, with the helm of affairs, when somebody comes to the senior position, they used to do that. And the senior most always will become the dean. That was the process, now it has changed. Then it so happened that 115 acres belonged to Bangalore Medical College. That was the biggest shock to me, and all the other projects I had to frame up. And my favorite, my pet institution is what today is named the PMSSY Super Specialty Hospital. So that was my dream, which was my brainchild, I decided that all the super specialties should come under one roof, give the poorest the poor the best of treatment in neurology, neurosurgery, cardiology, plastic surgery, all the super specialties, and above that, the intellectuals of the country should turn out more super specialists to serve the country better. Because that was a lack, because when we don't have post-graduation, super specialization, we can't do anything with the manpower. The manpower will remain lower and lower with the seniors retiring, it dwindles with you. So it so happened. Ultimately, it really came up to the value of what it is.
Please.
What I want to tell you, the value is,
I'm glad you could make it. Please, 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 John, please, John.
the value is that it came up to the level of accepting super specialties, and today the institution has gone and to compete with the government of India on the 100 crore project. The government of Karnataka was headed then by the then CM Kumarasamy. He gave 150 crores as a matching grant to value the development of the entire organization, and 250 crores just poured in, just transforming the center. So everything is laid in form, sir. And I promise you that the present man will definitely collaborate, because the volume of the large amount of clinical material we get throughout on all the 5 hospitals with very specialized areas of eye care, maternity and super speciality, and in general, I'm sure there won't be any volume for the collaboration, and I'm very happy that the e-health sector of IIIT has taken over disabilities and also the care of the senior citizens. And geriatrics is a very special field today, which is the most neglected field in today's way of looking at health, because they are sent and they don't have a definite department of geriatric care. Geriatrics department doesn't exist in many of the hospitals, including Bangalore Medical College. And I think it's high time that many of the medical colleges propose to the government to initiate the move to have a geriatric department, a specialty course of MD, and then move it at a high level of the Medical Council of India to come and inspect these areas and start this new specialty. At least in Karnataka, we have, I think only one center is running it, that is JNMC, with just 1 seat or 2 seats, Madras Medical College with 2 seats, and AIIMS New Delhi with 2 seats. This is the small number of specialists in this field compared to the volume of the geriatric patients who would outnumber in the course of time and beyond to 2020, exceeding even the new birth, the young population. So they're going to be an economical burden on the country, and I think, as you said, the devices that have to be developed are to be added more to the value to make them more self-reliant, and rather than being, as most of us are not able to take care of our own parents being away and due to certain commitments, it's not that we don't want to do it for them, but lifestyle also involves many of the processes that we have to venture out to satisfy our career prospects and other care and all that, and I think they got to be taken care of, and I think they should be, that is a value, and I think your research will further up on this particular care. I think multitude of volume of storehouse, I should say a warehouse of information, as well as the value of what you going to get data mine, I think you will get for your research in a big way, and I'm sure IIIT is going to go very well if we can collaborate, and definitely I will do the needful by bringing the contact between the institution and my institution. Thank you.
Thank you so much. So now that Dr. Devi Shetty has come, sir, thank you so much. I understand that you had some urgent, okay, so I think, we were all saying that you are one person who is always busy saving lives. I think that's much more important. So we have a quick question which people have been answering, maybe the same question I would ask. I think some of you, the students, you probably may not know that way back in 2003, the then CEO of HP, Hewlett Packard, Kelly Fiorina, was here, and in one of the meetings with Dr. Devi Shetty, she always said, here is one doctor who ensures that technology is driven the way the doctors want and not the way we guys want. So I still remember that, and I think he has been doing proud to all of us. Sir, we have basically 2 questions. Be brutally honest, there's no press. Has IT delivered at all for medicine? And second thing is, if it is not delivered, we will kind of work on it. What are the 1 or 2 things which you think we should actually do so that we genuinely make a difference to the larger healthcare scenario in the country? Thank you.
First of all, if you ask the question about whether IT has delivered, no, it hasn't.
Okay, that's good.
It hasn't come anywhere close to what it can do.
Yes.
And just to give you an idea about what IT can do, is the entire concept of delivering healthcare will undergo dramatic change within the next 5 to 10 years' time. First thing is let's go into the real healthcare. I believe that within 5 years, smart software will make smarter diagnosis than us. And within 10 years, it will become mandatory for doctors to get a second opinion from the software before starting the treatment. It will become legally mandatory. Now, I give the time frame as 5 years and 10 years. The reason is I don't want my colleagues to shoot me down. It is going to happen much sooner.
Faster.
Also, the way we look at the hospital, the healthcare will undergo dramatic change. All the doctors with a big outpatient, hundreds of patients waiting outside, like I see more than 100 patients a day, it's going to disappear. People are going to see doctors online. And online healthcare will be much, much easier than online retail, logistically. I'll give an example. Supposing a shopkeeper selling a very unique sweet in Jaipur, I want the sweet from him. I place order online. Someone has to pick it up from there and pack it in a manner that it doesn't get squished during the journey and doesn't get spoiled because of the temperature and whatever. Then it comes to the airport, somebody has to physically pick it up and bring it to my house. Right. This is you look at the logistics involved in bringing that material. Same, the shop owner gets chest pain. Right. And he contacts me saying I have a chest pain, and I talk to him on telephone and I take the history. Then in Google Map I know exactly where he's living, and I know the diagnostic lab, good diagnostic lab close to his house. Then I will write a set of investigations. I will tell him that you go to this diagnostic lab at 1 o'clock, they will do all the tests. And they will do the tests, and before he can put on his clothes, I have all his ECG, echo, whatever blood tests, everything, I have it in front of me. Then I can tell him, I have just seen the reports, everything looks normal, you have no heart problem. Just continue your life, but control your diet. It's finished.
So he doesn't have to travel at all.
Because 99% of the healthcare problems do not require operation. When I don't need to operate on the patient, I don't need to touch the patient. If I don't need to touch the patient, I don't need to be there. I can be anywhere. But the problem is all the software engineers are fiddling around at the periphery, controlling the calorie of what I eat, or how many kilometers you are walking. They're wasting their time. None of them are bothering to come inside the hospital, sit with the doctors, because we are very finicky. We want things to be done the way we want. We don't want any one of you to tell us how to run our services. So your job is to change your way of working, suit our requirement, because we are the end users. We have the right to decide how a particular software should run. But that's not happening. You come up with a product, say, can you use it? We don't want to use it because that doesn't fit our requirement.
I know this is something which, remember that you had come, thank you. You had come couple of times when C.K. Prasad used to use the term co-create, So something which we have not been doing. In fact, that is something which I was kind of talking to others also. For some reason, engineers and doctors, we have not been talking enough.
Next 100 years, they will never be able to come up with anything which will be applicable for healthcare if they don't work with the doctors.
Yes.
They have to sit next to each other and discuss, otherwise it will
Yes. But okay, just tell me one or two concrete ways by which things can happen. So I tell you, okay, my generation possibly would not do, but I think Jaya's generation is willing to do that. So now, at least for the next generation of student, next generation of younger faculty, they are not worried about, Dr. Dinesh J. Gopi does, interesting stuff. He actually goes and talks to the people, talks to the kids, talks to the, kids who are retarded and stuff like that. So, but what happens is that somewhere along we get lost because we really need a guided tour from the doctors of how to approach this broader medicine. Otherwise, what happens is that we get lost in what we call the Microsoft stuff. The sense we have so many features, we love the features, but the features don't work or the features don't make sense is not something which we are able to see. Can you think of some constructive ways of kind of building this bridge?
See, first of all, doctors are very busy people.
Yes, we understand.
So, whoever wants to develop something worthwhile, they should change their clothes to our OT clothes.
Okay.
So they can come along wherever we go.
Okay.
And to be honest with you, when we tell you first that this is what we want, when you come up with that, we use it, then we get excited, then we say, this is not what I want something more. And you come up with something more, we are ever so demanding because our job is very, very complex. So we are difficult clients, right? Because we deal with life. It's not like online retail. Maximum what will happen. Your material may not reach you, but here we make a difference between life and death. So we are difficult customers. So if they want to really do something worthwhile, they have to be with us.
Okay.
They have to have lunch, breakfast, and dinner with us, right? And whenever we find time, we'll interact, and they come up with something. We use it. It works. If it doesn't work, again we start all over again. So it's a tough job. Yeah.
Okay, that's good. So we get the message. The only thing is that as we are again impossible optimists. As they say, when the going goes tough, we get tough. So we will get it. Okay. So we have another about 20 minutes or so for some questions. Okay. So I would kind of open it out to. Okay.
Hello, my name is Sanjeev. I represent a company in the healthcare IT space called Medif. I was at HIMSS in Chicago about 4 or 5 months back. And I just heard something very similar to what Dr. Devishetty just expressed from a group of doctors who were on a panel. The doctor said that the IT people today are using their inadequacies to put pressure on us and to make us work the way we don't want to. A very simple example they said was in OPD, if I'm sitting and seeing a patient, they're asking me to put all the information online in the system, in this field, that field, blah, 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 which I don't want to do. And that takes away my time, it takes away my very important contact with the patient. Instead of telling me to do all this, I expect that they should have an audio-visual system around me. They should capture all my interaction the way I do with the patient and translate it into a structured data or whatever they want to call it, big data, and run analytics on that. Is that what I'm hearing from them? Is what you wanted to say?
Please go ahead. Yes. Yeah.
Yeah. I just want to.
Yeah.
I don't wish to name the software, the EMR in the US. There are $1 billion EMRs, $1 billion, the top few EMRs. If a doctor has to use that EMR, he has to undergo 76 hours of training. Then 76 hours of training will allow him just to learn how to begin using it. But in between that, he has to undergo several hours of training. Then after all the training, if he wishes to use it in his day-to-day practice, in the outpatient, if he uses the EMR, he has to spend 30% more time with the patient. 30%. So to overcome that, when doctors started grumbling, the hospital, the organization management started hiring scribes. So now there is a doctor, there is a scribe, right? And it is such a big headache. Today, when you look at the doctor's dissatisfaction with profession in US, software EMR is one of the main causes. And to the extent, some of the new hospitals, when they advertise, they boldly advertise saying that using EMR is not mandatory. Technology should have made us to spend less time. Technology should be available to prevent us from making mistakes, right? And it should be a joy using the technology. Why we love iPhone? Because there is no instruction manual. You give me anything with the instruction manual, I will never use it.
So essentially this is the way people are. So if you are going to develop something with a big instruction manual and a training program, nobody is going to use it. So what we really need is something which will save our time. I should spend 30% less time by using EMR. I don't need any scribe, and more than anything else, it should prevent me from making mistakes. That is a fundamental requirement. If you say that you will be as efficient as you are today, I'm not interested. I will be wasting my time. You should say that, Doc, you use my EMR, you will not make mistakes. And what mistakes we make? We forget to ask some questions. We miss out something which should have been known to us. This is how patients land in trouble. So this is what we want EMR to do it, but that's not happening.
Okay, so I'm glad. Thank you. So, okay, Dr. Chinappa, you have. Then we'll come back. Okay.
I'm Dr. Jagdish Chinappa. I'm a pediatrician, so I'm from the other side of the river, so to speak. It's a very fascinating discussion today, but being 35 years in practice in pediatrics, I just have a couple of issues. The first one was an interesting interaction with Dr. C.K. Prahlad and Dr. Prasada Rao, which was in the Infosys campus many years back. And at that time, there was a dream of creating 2020 health policy for Karnataka. And I sat on this for about 6 to 8 months on how to reduce the infant mortality rate, which was one of the priorities which Dr. Reddy was mentioning. And we looked at what are the possibilities, how we can do this. And at the end of it, we looked at, after all, Karnataka has about 27-28 districts. And if we can pair up one of the district hospitals with one of the private institutions providing high-level intensive care in newborns, and take charge of training, take charge of managing that intensive care unit, and have a hub and spoke model of all the villages around that district referring into that hospital who can take care of even the most complex cases, we could reduce the infant mortality rate quite significantly. We went through this, and there were enough sponsors from the CII who are willing to give money to this venture to try and put this technology in place. However, as usual, what happens is that the private sector is talking one thing, the government sector is on a different focus altogether. Unfortunately, sorry to say, but the government sector is all vertically oriented. That is, they have programs running in vertical. Right? For example, the ideal thing to do would be to create a model health village. You have a village which has got all components, because I believe that health issues are not constant. You have severe malnutrition in children today. Tomorrow you may have fluorosis. You may have something else. So it has to be responsive enough to pick up another disease quickly. So I think that is the key feature of information technology, that it can look at trends. Supposing there is a trend of, let us say, fluorosis occurring in a village, that should be quickly alerted to the healthcare system and some action should be taken. So I think there are a lot of challenges. We have reached up to a certain extent, but again, the problem with the health IT, as far as I can see, is that it is totally disjointed. There are all bits and pieces of people doing some kind of work, whereas not something comprehensive, something which has a leadership, it's something which has got investment in it, something which has deliverables and something that can be measured. Those things are not there at all. And I'm sorry to say, these are the basic lacunae as far as the health IT is concerned. Professor Shetty has given a lot of futuristic kind of IT things which we will get into. But at present, I think we have major challenges in even the public health format. And one more point is, as far as Kerala and Tamil Nadu is concerned, why do they have such good public health? One is Kerala has got a fantastic literacy rate, and Tamil Nadu was the only state in the entire country to have a public health service. And that is why they have done really well. And now Karnataka has. They have implemented in the last couple of years. But I think traditionally, Tamil Nadu has had a very strong public health service. So I think it's very, very important or vital, if you're going to solve the problems of the population, is to strengthen the public health service in many ways. And I think these are some of my thoughts which went through after all the discussion, all the fruitful discussion which is going through. Thank you.
Thank you, sir. I really appreciate. I think Professor Sridhar, you had a question? Okay, or sorry, Rajesh. Okay, sir. Okay. Yeah. Professor Srinath. Okay, yeah.
Good afternoon. I'm Rajesh from Wipro. And last few years I've been working on developing solutions for remote monitoring of patients, and we've been focusing on cardiac care and pregnancy care. Okay. And this question is to Dr. Devi Shetty, because the same solution which you developed here, which has a front-end device and all the mobile application, the back-end algorithm and all that, is sold in US by a startup company. They got funded $25 million to take it to market and they're FDA approved, okay. Whereas in India, we're struggling to reach the right size, okay. Whereas in the other way you look at it, India is the center for cardiac problems, right? Now we have the highest number of cardiac issues in India, okay. Why the mobile cardiac telemetry is not picking up in India? Because this is an area which is very keen to applying engineering to it. We have sensor devices, we have mobility, we have big data and analytics running at the end to find out disease conditions, to relieve doctors' time in terms of finding out conditions. Why, in your view, things not picking up?
I think, first of all, I need to see this product what you have made. The telemetry and remote monitoring is happening now, but of course not in a large scale. The biggest problem in this country is, in the end, there is a need for someone who can interpret all these findings. You may get the data. Unfortunately, our biggest problem in India is we have very, very few specialists, especially the areas like cardiology. We hardly have 2,000 cardiologists for a country with a population of 1.2 billion. So there aren't that many people who can interpret the data what comes out of. That's one biggest problem. Then the other biggest problem is super specialty. Telemetry is usually used by electrophysiologists. In the whole country, there are not more than 100 or 200 electrophysiologists. So that has been the biggest problem. Whenever you go to super specialty areas, the reason, if you really look at whether all the problems of this country, is predominantly because we have created an environment where we produce thousands of doctors, 56,000 undergraduate seats in medical college, and only 14,500 PG seats. So these MBBS doctors can't interpret any of those. We have created the regulatory structure in a manner that MBBS doctor can't do anything more than a housewife. It's very sad. So the regulation doesn't permit. We have, I'm a heart surgeon. If I do a cesarean section, I can lose my license. And the basic things are not allowed to be done by MBBS doctors. On the other hand, you look at US. US has 19,000 undergraduate seats. They have close to 40,000 PG seats. So why these high-end devices are not getting used in India is predominantly because of the problem of shortage of specialists. We have highest maternal mortality in the world. Every 10 minutes, one pregnant lady dies. Now, all our policymakers, government wants to spend more money. We think by spending more money, maternal mortality will come down. It can never come down. I'll give the data. 26 million babies are born. Conservative estimate is that 20% of them will require a cesarean section. That means we need to do 5.6 million cesarean sections per year. To do 5.6 million cesarean sections, we need 2 lakh gynecologists, 2 lakh anesthetists, 2 lakh pediatricians. We only have hardly 30,000 gynecologists. Half of them do not even practice obstetrics. We have 20,000 anesthetists. How do you reduce this maternal mortality? So our biggest problem is the shortage of medical specialists who can use all those fancy tools.
Thank you. Lots of insightful data. Professor Srikanth, yeah, you can just, yeah.
I just wanted to, my name is Srikanth. I'm a data scientist here at IIIT. So I just wanted to add to this perspective of IT in healthcare from the data science perspective. From my opinion, in terms of working on big data and lots of analytics kind of work is the only thing only person or the only job that an IT solution can really benefit is a clerical process. Beyond that, IT engineers are actually playing with fire whenever they try to automate the process, and because at the end of the day, a computer only works in a closed world paradigm. It just knows what it knows. It doesn't know what it doesn't know, and it assumes everything unknown as false, and so on. So it works in a completely mechanistic fashion. while any kind of science and profession like healthcare and so on works in an open world where you need to change your models on the fly, change your understanding on the fly, and so on. And so I think we are actually looking at an extremely hard problem here, which is probably an opportunity, but more of a research opportunity.
Yes.
But I would be very pessimistic to offer any good solutions right in the future.
I'll tell you, you think our job is very complicated. Okay, it's not. I'll give an example. First, you have to understand we are all human beings and we have some way of analyzing and coming up with the diagnosis. There are only 6,000 diseases you can suffer from. Out of that, 1,000 diseases are common. And when a doctor looks at a patient and takes the history, in his own mind, he cannot analyze more than 100 to 200 diseases. Now, there are 6,000 diseases. There are 50,000 signs and symptoms. Signs are what we elicit. I look at you and say you're jaundiced, or you have, you have anemia or whatever. These are signs. And symptoms are what you complain about. That I have pain in the back, pain in the stomach. There are only 50,000 of them. You can't complain about more than 50,000.
That's good.
And there are 50,000 lab findings. That is the blood test report, serum cholesterol, all this. So you have to match 6,000 diseases with 1 lakh signs, symptoms and lab reports. The software of a mobile phone can do it. Well, you don't need algorithm. So essentially, you see what happens when you talk about the research part of healthcare, then it becomes complicated. We are not talking about the research, we are talking about a patient in front of me, I have to treat him, he has a problem. So when I am going to treat a patient, what happens in my mind can be easily done by a computer. And secondly, you must realize that we are doctors, we see large number of patients. We don't expect us to have presence of mind all the time. We may forget to ask some questions. And that forgetting to ask that question can be a difference between life and death for him. So essentially why we insist that going forward software is the only way is that will make us more efficient. I see a patient at 12 o'clock in the afternoon, I see the angiogram, I tell the patient and his wife, here he has a blockage, he requires a bypass, and I give the instruction on a piece of paper. And they take the instruction, and just before leaving the room, the wife would turn around and say, Doc, I forgot to tell you that my husband is hypothyroid. Right? And then I make them sit there again, ask for some investigation. Fine, nothing wrong. I mean, any doctor can miss something, but I would have given the date for surgery after 1 week, but the patient developed chest pain same evening, at evening 8 o'clock or 9 o'clock, he comes to the hospital. My assistant sees the report that Dr. Shetty wanted a bypass to be done. They straight away take him to the operating room because he's unstable. Without 12 o'clock at night, you don't expect a doctor to ask whether he's hypothyroid. And you do the operation. If he is grossly hypothyroid, he may not survive the operation. So you see, technology is the one which will prevent us from making mistakes. Because technology doesn't use the brains. It is not dependent on what time of the day it is.
Okay. Thank you, Doctor. I think it's kind of very insightful. You talked about that 50,000 and 100,000. It's amazing. What it actually shows is we kind of never sit with you people to understand that. I think that is what is the ultimate takeaway is we need to sit together. And as you said that you can't happen these things cannot happen in 1 hour discussions, etc. We really have to do like the Guru Shishya style. As you said that you have to walk with you to the theatre. Okay. I think what happens is much more level of intensity. I think that seems to be the real missing link. So,
I fully agree with that. One need to, IT people work in one side and the doctors work in another side. Unless we come together, work together, we will not be able to find out. And this is what is required. We have a lot of requirements on our side, but we don't know how to express it even. So unless you come together with us and sit together, we will tell you many things. I will for small examples I'll give you. For example, we have an electrodes, which are very important devices which we use. These electrodes are imported and it can be manufactured here. It is nothing big. But we are not manufacturing, and we are now getting imported every time. Possible with the technology to develop that. It is possible, but what it requires is a person, a doctor who uses, has to sit with them and then understand what are the needs and how it works. Unless we sit, it is not possible. That is what is required. Another area we have not touched about is about the research, which Dr. Shetty has just touched upon. In this research, I wanted to say something very important. We have 1.2 billion population. When we have a large population, the magnitude of the problems are also very large. But there is an advantage on one side. We can look at the research point of view. We have a large data available. And this data, to get it in a Western country, it takes years, or it may take multiple centers to look at it. Here in one center, we can get the data. But that data requires to be looked at and analyzed properly to see what can be derived. An example could be biomarkers. We have now looking at biomarkers for various disorders. We look at an MRI. An MRI can be just look at diagnosis and go away from that. But can I look at the MRI and then see what biomarkers can I use for diagnosing a case of dementia? If I ask that question, we can easily look at that. But for that, a large data is required to homogeneous data and to analyze further, where analytics comes and we look at the data in a larger number. So we have both here in this country. We have a large data available, but analysis of this and then meaningful data to be derived from that is the use of technology. And that is where I require help from IT professionals, where they can sit with us, as Shetty has pointed out, that we can think about making the research from those angles. That is what exactly is very, very important, and we should take it further, not only from the diagnostics, delivery, but also from the research. That is the way out.
Thank you, Doctor. I really appreciate. I think we had a very interesting, lively kind of discussion. And the main takeaway from this is simple. We always knew it, but we did not know it in such depth that how far we are away from the problems which we are trying to solve. Hopefully, the advantage of Bangalore is that Bangalore is one city. I come from a town called Chennai. Okay, so obviously I can tell you, I also kind of share notes with my friends from Hyderabad and Trivandrum. Compared to every other city in this country, this is one city. However much people may differ, they at least sit down and talk. So this is one city where people talk together. So hopefully we'll kind of come together and learn. And also the fact that both the academia and industry, a significant number of people are there. And of course, Electronic City is also blessed because Narayana Hridayalaya is right in our backyard. And of course, you know, people like Dr. Ramana Reddy who are in the government also has been helpful. And we have a policy planner, Dr. Nirmala Murthy, has been kind of looking at it, giving us some insight. Hopefully, we will not let you down. And of course, the mandate is for Dr. Jaya Nair and her team that all that I would say is it is definitely a hard problem. And as the good old saying goes, you know, we go to moon not because it is easy, but because it is hard. Let me kind of repeat the same thing. So this problem is much harder. But I think together we will kind of crack it. And all that I would say is with no arrogance, if you can't, who else will? So I think, you know, being in Bangalore and, you know, being in the Silicon Valley of this country with such exemplary people, and, you know, as I mentioned repeatedly, you know, all these people just came for one single mail. Okay, so in the sense that people are willing to chip in, willing to sit together, and hopefully we will learn. I think that is what in that positive note I will end. And please join me in thanking the outstanding panelists.
We would like to thank the panelists and the moderator for conducting such an enlightening discussion on the use of ICTs for healthcare in India and their thoughts on some of the leads EHRC could work on. Now, on the behalf of the eHealth Committee, Professor Amit Prakash will give the vote of thanks with a note on what is ahead for EHRC.
Come.
Okay, thank you so much for such a involved and insightful discussion that sets an agenda for research at the eHealth Research Center that we are kind of launching today. We are very much in agreement with the spirit of the discussion. We see the eHealth Research Center as a collaborative platform, as a platform which provides space for collaboration amongst researchers, amongst practitioners, drawn from diverse fields. So we also take the spirit of transcending disciplinary boundaries when we are doing this research. The disciplinary boundaries that involve computer science and electronics, social sciences, health sciences, representing diverse organizational forms from the private sector, from the delivery organizations, from device manufacturers, all of them. We all know that increasingly innovation and creation of knowledge have been doing this. Maybe this has been all along done, that you need to transcend disciplinary boundaries to be able to achieve something meaningful in terms of creating knowledge and making difference to lives of people. It is the unleashing of these combinatorial possibilities that interdisciplinary conversations have enabled that are increasingly leading to cutting edge products and solutions, especially in the high technology space. So when we talk of products that were discussed here, it's not one discipline that has actually contributed to manufacturing those kind of products. It's these kinds of conversations where users and different stakeholders come together and interact that such opportunities have been created. We feel the strength of the new eHealth Research Center will be in terms of fostering long-term and sustainable partnerships for research in eHealth, which can lead to improvements in the quality of life in all our societies. A basic version of the EHRC website is operational, it's up. I think you'll probably know the URL, but it's still a very basic form where we have put together a list of faculty members at IIITB who are interested in doing research. We welcome all of you to write to our faculty members on exploring joint work. We'll also, from our side, keep writing to you to try and figure out if we can jointly work on research problems that may be meaningful and that may make contributions of the information technology industry and field much more meaningful in a society like India. Thank you again. Thank you very much, all of you, for participating, especially all the invited guests and all the distinguished panelists. Thank you to all my colleagues, all my faculty and staff colleagues at IIITB, and especially to my fellow colleagues in the eHealth Committee for making this launch possible. And we have started this journey on a very positive note. We hope we'll go along that. Thank you so much.
Thank you all once again for being a part of this event. We now invite our esteemed guests to join the faculty and staff for lunch. Lunch is served on the ground floor outside the director's office. Our student volunteers will guide you.